Now we're in Belgium, and we're very grateful to have Professor Jan de Waal, who's going to present on a very challenging topic, which I'll talk about very soon. Jan is a critical care physician at Ghent University Hospital, and he is someone who I've enjoyed a very long-lasting collaboration and friendship with for many, many years. And when I thought about this topic, about why we're seeing different outcomes in critically ill patients versus maybe patients in the ward but still requiring oxygen or not requiring oxygen, I thought that this was a really interesting topic, which it'd be great to have a very logical and scientific mind think through what some of those issues are. And so it's wonderful to have Jan join us and present on this really challenging topic. And I can't wait to hear what his views on this are. Thanks, Jan.
Thank you very much, Jason. It's a pleasure and an honor to be here. Good evening, good afternoon, good morning, wherever you are. So I'll try to give my perspective as to how or why critically ill patients are different and what that implies for their treatment. These are my disclosures, none in fact of them relevant for this particular presentation. Now, before going into detail into the question, I just want to give you a brief update on how we've been experiencing the COVID pandemic here in Belgium. This is a picture from the Grand Place in Brussels. I'm sure many of you know this, and normally it's much more lively, and I hope we never have to see this picture again. Thankfully, we're now in a less severe situation, but there's still a lot of restrictions in our society that we hopefully will get rid of very soon. Just to show you some numbers on how the pandemic went, this is the 7-day average of new cases per 100,000 inhabitants. And you can see that, yes, of course, in the first wave, everybody had a lot of cases in and around Europe. The wave was much smaller because we only identified patients with infection who were actually admitted to the ICU. So no, it's presumed that this figure is actually that the height of this wave is much higher. But you can see that in October, November, we were really hit quite hard, and our second wave has been very challenging and in fact much higher than what we've seen in the US, the UK, and other countries around Belgium, where they've also struggled with this problem. And this was also picked up by the media internationally. And of course, this is not the kind of person you typically want to be associated with, but you could see Belgium here leading the charts in terms of mortality. This was because, well, we had a lot of cases, of course, but also because actually every suspected case was also categorized as a COVID positive patient. So this is why the mortality was very, very high. And in fact, the excess mortality later on was comparable to other European countries, albeit it was still in the higher range. We are, of course, a small and densely populated country with a lot of traffic going through it that certainly contributed to the spread of the virus in our country. This is some information to give you an idea on how the strain on the hospitals was. You can see that actually the second wave, we had almost 7,500 patients in the hospital at one day, and also in the ICU, almost 1,500 patients. Now, Belgium has a population of 11 million approximately. Our normal ICU capacity is 1,600. It was at that time expanded to 2,000. So we barely managed to accommodate all of these patients. Also, please keep in mind that our ICU capacity is about 3 times higher, for instance, to our neighboring country, the Netherlands. So again, just to give you an impression of how bad the situation was at that time. Biggest challenge in our first wave was the lack of personal protective equipment and being unfamiliar with the disease, of course, and that has changed significantly in the second wave. So let me go back to the question. The question here is if it is really critical illness per se that changes the treatment, or is it the fact that being critically ill means that the patient is just in another phase of the disease. So clearly, from what we've seen before, the excellent presentations on the different potential therapies, actually at the same time, it's astonishing to see the amount of research that has been done in the past year or in the past few months. But at the same time, it's really frustrating to see that still we have very little to offer to our patient, particularly the most severely ill patients. Well, patients get steroids, and that's about it's when they're in the ICU. An important thing to remind you of is that critical illness, of course, should be interpreted differently when you are at the peak of a pandemic. This was the same in the UK, for instance. At the peak of the pandemic, critically ill patients were throughout the hospital. Many hospitals only admitted patients that required mechanical ventilation in the ICU, and a lot of patients on high flow nasal cannula with really low oxygen saturations were managed in general wards. So the distinction between severe and critical disease is no longer based at that moment on the location where the patient is hospitalized at that time. You've seen this picture before, and I think this is a key to understand how, in fact, the patient goes through different phases. Oops, apologies for this one. Different phases. So at the first stage, it's really the viral replication that is driving the disease. But as the disease progresses over time, and these patients often have a very consistent disease pattern. As the disease progresses, it's that inflammation, that hyperinflammation that takes over and that drives, well, that brings the patients to the ICU essentially. And this is very important, I think, in terms of understanding which treatment is given to the patient. And treatments aimed at the hyperinflammation, for instance, given during the first 2 days are, in my opinion, probably not the best solution. And the other way around, giving antiviral drugs at the late stage probably won't bring a lot of benefit to the patient. So I think this is a key thing to understand, because remarkably, all these patients go through the same disease process. Initial symptoms at home for a few days, then they get tested positive. They may have persistent symptoms or even a deterioration, which then brings them to the hospital. And often they are in a general ward or a medium care ward for a number of days and only get admitted to the ICU when they're 10, 14 days into the disease. So when they enter the ICU, or actually something else is driving the disease, and that should be the obvious target for intervention. And this also transpires in a lot of recommendations that are now available. This is the WHO, but the latest Surviving Sepsis Campaign recommendations actually follow the same logic, where patients, when they're not hospitalized, actually, or hospitalized without the need of supplemental oxygen, recommendations against the use of dexamethasone and corticosteroids, again, which makes sense when you look at this progressive disease model. Once a patient gets hospitalized and requires additional oxygen, that's when there's a potential of to give antiviral drugs. And also at this stage, as the disease is progressing and this hyperinflammation is taking over, that also steroids could be beneficial. And only when a patient is actually requiring high flow nasal cannula or invasive ventilation, these patients are definitely are the ones who would benefit from giving corticosteroids. So it's not so much critical illness per se, as we know it from other disease states, but it is what drives the disease that actually should impact therapy. Now in our ICUs, of course, our main focus is on respiratory support. We do use a lot of high flow nasal cannula, much more than in the first wave. In the second wave, it was used widely. And actually, we do think that we prevented invasive mechanical ventilation in a number of patients. Non-invasive ventilation is something we rarely use. And the most challenging discussion and the challenging decision is to decide on the threshold for intubation in these patients. This is still at this point, after seeing hundreds of patients, it's still a difficult thing to decide. And the only thing we administer currently for these patients is dexamethasone. We do participate in a number of clinical trials on many of the treatments that have been discussed by the other speakers. But so far, that's the only thing we do. What we did see during the second wave is that probably or presumably, that's at least what we think, because of the fact that these patients were already treated with corticosteroids when they were in the general ward on high flow nasal oxygen, for instance. We've seen a different type of patients presenting to the ICU, much more often with severe disease leading to protracted treatments. We've seen a much higher need for ECMO, for instance, in this second wave. So probably by giving steroids in the general ward, this patient selection, that patient that goes to the ICU, is also changing over time, and generally, to in our impression, more severely ill. The primary problem still is hypoxia. It's not pulmonary embolism when the patient presents. It's not septic shock. Patients rarely are in shock, in fact. I do want to elaborate a little bit on the pharmacokinetic changes in COVID-19 patients. And obviously, when patients are critically ill, as in other critically ill patients, this should be considered. There's a number of typical patient characteristics and treatment characteristics that actually may affect pharmacokinetics differently compared to other patient categories. Obesity is one of them. I'm sure that those of you who've seen and treated patients in ICUs, that this is one of the consistent features of patients admitted with severe disease. We are much more restrictive with fluid management compared, for instance, to patients with sepsis or septic shock. And we definitely want to avoid overload, but we be very restrictive throughout the treatment once patients are admitted in the ICU, but also in the general ward. As I mentioned, higher use of ECMO is something we've seen in the latest wave. And hypoalbuminia is also a very common thing, particularly in the most severely ill patients, being the ones, of course, who are in the ICU. The kidney function is also worth looking at in COVID-19. Looking at a patient profile, elderly patients with often comorbidities, and chronic kidney disease is often one of them. AKI, because is common as well, because the virus itself also directly affects the kidneys. This has resulted in a quite common need for renal replacement therapy. In some studies, up to 25%. It's not been our experiences, but definitely something to consider. And again, this kidney function profile is quite different from a typical average ICU population. Augmented renal clearance, something that we're often concerned with in general ICU patients, is not that common. There's not a lot of data out there, limited data from Spain, but you would think that this clinical picture of this hyperinflammation and a lot of fever would also predispose patients to augmented renal clearance, but that doesn't seem to be the case. There's a few studies that looked at antimicrobial concentrations in patients with COVID. This is a very small study from France. It's just showing you, of course, the different patient profile, more elderly, more obesity and chronic comorbidities as well, and a particularly respiratory insufficiency issue at admission, resulting antibiotic concentrations here. And apologies for the fact that this was cut off on this slide, but you can see that the antibiotic concentrations are probably not very different from what we see in the general population. But again, what is striking is the ranges, the variability, the inter-individual variability. And therefore, pharmacokinetic changes could be more relevant also in COVID-19 patients for the different drugs that we've been administering, what we've been studying. And it's only rarely that I've seen pharmacokinetic differences or issues being discussed with any of these new treatments. Just before finishing, a few words on antimicrobial use. We've seen a high use of antimicrobials in the first wave because of this fear of bacterial superinfection, as we've seen often in influenza. This was unsubstantiated, and actually we are now much more restrictive. As mentioned, we've seen septic shock only very rarely in patients when they present to the ICU, and co-infection, we do a lot of CT scans. Well, we do CT scans probably routinely right now, and these typical bacterial infiltrates, you will rarely find them in patients presented with COVID-19. So our current standard of care is not giving antimicrobials at all, also in critical COVID, and only while using this flow chart only in patients that do present with septic shock or where you have imaging suggestive of bacterial pneumonia, we would initiate antimicrobial therapy. Of course, it's important to sample patients, and we were reluctant to sample patients in the first wave. We did sample all of them in the second wave when there is a suspicion of infection, to really document it and to help us guide therapy. Now, I do want to end with a few learning points that are not related to critical illness, but just general issues that I do feel are worth sharing. First of all, we had to expand our capacity, and there's been a lot of discussion also in the media in different European countries, including Belgium, about expanding capacity and thinking that if you have a bed and a ventilator, that you have an ICU bed. And clearly, the biggest challenge is finding skilled personnel to take care of the patients who are in these ICU beds. So ICU healthcare workers are the most precious asset that you can have in such a situation. You can never be prepared enough. It's often much bigger, and there are much more challenges than you expect. So if you have the time, do prepare properly for such a pandemic. Creating a safe environment for healthcare workers, I think this is very important. The lack of PPE initially was a challenge and was a concern, but making it available now, having consistent and clear guidance, adequately communicating with everybody who's taking care for patients in the ICU and beyond the ICU has proved critical to keep the majority of our healthcare workers on board. There's been very few people actually catching the virus, and almost nobody dropped out because of burnout or related issues. Sticking to evidence-based medicine, I think, is really important. We've seen a huge amount of potential therapies been advocated by many people, in the end turning out to be not only not beneficial, but probably harmful. So that's definitely an important one for me. Once your patient is in the ICU, it's about patience. You need to wait a long time, and often these patients have protracted disease. Patience there is really important. And the last thing I do want to mention is don't lock the family out. That's something we did in the first wave, but we didn't do in the second wave. We've seen patients dying without any family members around, and family members still suffering months after that about not being able to be there for their family. So with this, I would like to thank you for your attention, and I'm more than happy to take any questions.